afternoon, everybody. Welcome to this afternoon's session. I'm Tina Coldham. I'm going to hopefully share us and navigate us through this afternoon. This is a talk about community-based services for people with complex emotional needs by the Mental Health Policy Research Unit et al. In the fact there's a cast of thousands, and indeed we have many people joining us today to take part, to listen, to hopefully interact with us. Now, 2 years ago, in January 2019, where things were normal, whatever normal is, and that's for another day of discussion, but we were all in a room and there was a lot of anxiety and excitement, and I think angst about this. For those of us who've been given the diagnosis of a personality disorder, we have a lot of vested interest in this. So here we are 2 years later in our own rooms. So normally at this point I go do sort of housekeeping, then there is some housekeeping. As you're in your own room, if you want to smoke, drink, go to sleep, go to the loo, do whatever you like, it's absolutely fine by us, okay? Do your own thing. But just to let you know that this event is being recorded, so it can be looked at again, and it's also being live streamed on YouTube, so it can be seen there. And the chat, any chat will be saved. And through bitter experience, I found out that even the stuff you think you send privately can also be saved. So be very careful what you say to somebody. Okay, moving on swiftly. So the recording of the research presentation will be shared afterwards as part of a take-home package for you. Okay, so that you'll have all the slides. And what the Mental Health PRU unit will do, we'll get back in a month or so with a link to a blog about the event and to copies of all the research papers, which will by then be available in preprint or as peer-reviewed open access, very important. And then when you see those, you can please distribute those to anybody that you think would be interested. Keep yourself on mute or we'll mute you, I warn you. So only the current panelists can be heard, hopefully. And if you want to turn your video off, then please do so, whatever you need to do to be comfortable. I'm sure you're all au-fait with your kits, but obviously you can fiddle about and see who's speaking and have fun with that, just don't lose us. We'll be taking questions about the implications of the research. There's going to be 2 panel sessions and Sonia will talk about the agenda. Now, if you have a question, please type it in the chat. Now, we had nearly 600 people register for this, so I don't know what you guys are doing on a Friday afternoon when the sun is shining here anyway with me, but you're obviously interested in it, which is very gratifying. But there's no way that I can see all of you and keep you under control, so I wouldn't even attempt that. So what we're going to have to do is put any questions in the chat function, and apologies to anybody who finds that difficult. But that way that we've got a team of people moderating, looking at the chat and keeping an eye on it. So if you've got a research question about the actual research itself, please ask it in the chat and the research team will answer your question through the chat. Okay, so again, we're saving the chat so you won't lose any of this information. Any of you who like to tweet, the hashtag on Twitter is #ComplexEmotionalNeeds, and I understand there's already people engaging on conversation on Twitter, so look out for that. If you lose access to Zoom and have difficulties rejoining, I mean, we've got Christian on tech, he's a little man pressing buttons, so I'm hopeful we'll be okay. But you can watch the event via the live stream. The link is appearing in the chat now. It's there. Is it there, Christian? The link to the... See, I knew we were slick. Anyway, in the chat somewhere is the link. Oh, yes, Andre's put it up. There's the YouTube chat, YouTube So if you lose us, you can click on that and get or save that somewhere and get in there. I mean, if you do have any tech issues, we have Christian from the uni and also Andre Tomlin, the mental health, with us, and they're going to help us with the techie stuff. Now, when you registered, you also registered for a preference for a breakout room. Now, because we've got so many people, they might not get what you really want, which is such is life, unfortunately. But Christian's going to do his best to put you where you want to go. But please bear with us. That might not be exactly the place where you want to be. Okay, so what I'm going to do now is pass over to Sonia, Professor Sonia Johnson, who's Director of the NIHR Mental Health Policy Research Unit, to introduce the research programme. Over to you, Sonia.
So you would think after over a year I would avoid starting with the classic speaking on mute error, but it seems not. So welcome to you all. We're delighted to see so much interest in hearing about our research programme. The Policy Research Unit is commissioned to provide evidence to inform mental health research policy. So our money comes from the NHS, the Department of Health and Social Care, but the views we express are those of our research team and not those of any government body. That's our acknowledgement. So next slide, thank you. So we're going to talk to you, really briefly summarise a programme of work that we've conducted to try and help inform policy following the NHS long-term plan, where there's a policy commitment to try and improve commissioning of services to support people who we're describing as having complex emotional needs. The programme we're going to talk about was overseen throughout by a working group that consisted of our research team plus a range of experts by experience and by occupation. And we've conducted a set of summaries, syntheses of the literature, qualitative research on perspectives on what's good practice. Basically, our aim throughout has been to try and come up with a reasonable overview of what looks like good practice for people with complex emotional needs. Now, an inevitable question is about terminology, and we could easily have organised a whole afternoon, or indeed many afternoons, discussion about what kind of terminology to use. We started by being asked to work on services for people in the community with a personality disorder diagnosis. That obviously has many problematic aspects, and we've been persuaded that it does come with a baggage of stigma and lack of therapeutic optimism that is such that probably it's not the best term to use going forward. We think there's a real need for some good co-produced work to decide on concepts and measures that are fit for the future. But for now, we've adopted this term complex emotional needs as a sort of term to be going on with to describe the needs of people living in the community who may be using services that are for people with a diagnosis of personality disorder, but we acknowledge it's not the perfect term and hope there'll be more discussion on that. So finally, the agenda for this afternoon, if you'd just like to show people that, Sian. So we're beginning with a set of quick presentations of our research findings, then 2 panel discussions with experts of various kinds, and finally we hope for your input on implications and priorities via breakout discussions. We're having many breakout rooms this afternoon to do that, and we're most grateful to you for joining us. And throughout, if you want to ask anything or comment, the chat is the way to go. Basically, we'll do our best to respond. Thank you. Tina, back to you.
Thank you, Sonia. So the meat and potatoes of why we are here this afternoon. First up, I'd like to introduce Luke Sheridan-Rains, who is going to talk about a bit about the scoping review. Over to you, Luke.
Thank you, Tina. Yeah, so my name is Luke Sheridan-Rains. I'm one of the researchers in the PRU, and today I'm going to be talking about one of the bits of work that we've been conducting as part of a wider program, and it's a scoping review of published evidence related to community-based treatments for complex emotional needs. So as we go, I'll say a bit more about what I mean by a scoping review in this particular context. But basically, we were looking to understand what evidence has so far been published regarding treatments, psychotherapies, that sort of thing, for people in this cohort, looking to, as Sonia mentioned, to inform implementation of the long-term plan. So when we began, we were aware that there were several good quality reviews that already existed that looked at psychotherapies for particular personality diagnoses, in particular borderline personality disorder. So for example, there's a Cochrane review that was last updated in 2020. And the aim of these reviews really is to pull together all published data regarding the effectiveness of particular psychotherapies like DBT, MBT, CBT, psychodynamic therapies, etc., or medications. But we were interested in, as part of our program, really, we were more interested in things like what good quality care looks like. So there were no reviews that we found that explored good service models or good quality systems of care. So we set out a couple of key questions. Firstly, how to have a good system of care with good continuity, good accessibility for service users, and how to foster kind of good therapeutic settings and good therapeutic relationships. Secondly, we wanted to explore questions around how to improve quality and embed helpful interventions within generic mental health settings, and also how to deliver trauma-informed or trauma-focused care to people in this group, and to help people in particular with sort of social and practical aspects of their lives. In particular, we were interested also in forms of therapy that perhaps hadn't made it into other reviews, in particular things like peer support and co-produced interventions that we just didn't see having been reviewed anywhere else. So we conducted a scoping review, and in this context, what we mean by that really is, as a first step of this work, we wanted to identify all of the evidence that had been published regarding community care, community treatments, and to ask questions about, where has the evidence been published, what kinds of treatments have already been evaluated, and what forms of care or treatments have yet to be evaluated or yet to have any evidence provided. So it was a sort of mapping review of the literature as a first step. So we searched the literature for any papers that have been published that had evaluated a treatment being offered in a community setting. So any kind of community mental health setting, so excluding forensic settings, crisis care, or inpatient care. And any sort of treatment, so this would include things like the evidence-based psychotherapies like DBT, CBT, etc., but also things like case management, therapeutic communities, peer support, etc. We focused on adult populations, so anybody over the age of 16 and who had been given this diagnosis of so-called personality disorder. Or we also kept it quite broad because, not least because of the issues around the diagnosis and the fact that people can potentially benefit from such support certainly without having been given any such diagnostic label. So we kept it quite broad and looked also for samples, papers with samples of people who had experiences that were sort of related to personality disorder diagnoses. Finally, we also looked for studies that used any quantitative study design. So that included everything from the gold standard of study design, things like RCTs, through to sort of poorer quality study designs which would be non-controlled observation studies, so what we call pre-post studies. Sean, could you move? Thank you very much. So in terms of our findings, we found about 240 papers that have been published in the last 30 years. We didn't limit our searches by date. It's just that the literature has been published over about 30 years. And approximately half of those 240 papers were RCTs of evidence-based psychotherapies. Those papers were conducted in a range of countries, but really primarily Northern America, UK, Western Continental Europe, Australia, and New Zealand. Now, we haven't yet pulled the evidence. That will be kind of step 2. But what we can say so far, just from our observations of the data, basically almost all of the evidence relates to specialist psychotherapies. So it all kind of relates to things like DBT, MBT, and just from looking at the what is the kind of consistent themes across those papers, we can say that there are often quite substantial improvements seen in these papers. Almost every paper reports some sort of improvement as a result of receiving therapy. And from our observations, our initial observations of the literature, it doesn't look like there are big differences really in treatment modality. So it doesn't particularly matter if it's DBT or MBT or whatever it is, but most notably, people do tend to really benefit from being offered this sort of care. We also noticed that, which is particularly relevant, I think, to this early step of mapping the literature, the RCT, so the sort of good, gold standard of study design, tend to be conducted in the same sorts of areas as the pre-post studies. So there are very few pre-post studies that relate to treatments or therapies that haven't already been evaluated quite comprehensively with RCTs, which this tends to make the pre-post study evidence fairly redundant. Can we move slide? Thank you. So overall, I think that some of the key findings that we have about the gaps in the literature include that substantial and convincing studies are lacking on most of the questions that we had at the beginning. So things like how to have a good system of care with good continuity, etc., and how to improve quality of services. Basically, that's not really been touched on really by the evidence that's so far been published. It almost all relates to what is the effectiveness of different psychotherapeutic modalities. Also, this evidence really tends to come from people who have a diagnosis of so-called borderline personality disorder. And even if an RCT isn't explicitly about recruiting people from who have that diagnosis, when they do recruit people who have other personality disorders, if you look at the samples, it tends to be really the majority of people tend to still have these diagnoses of borderline personality disorder. So evidence that relates to other personality disorder diagnoses and to other forms of treatment is really preliminary and often from these kind of poor quality pre-post studies. So in overall, we basically only found a small handful of studies that focused on collaborative care and shared decision making, which is one of the things that my colleagues Una and Kylie found in the qualitative literature has been really important. Also things like support and getting back into employment or education after treatment, interventions that combine, that take a kind of trauma-informed approach to supporting people in this group, that we found very little evidence on that area. We also found very little evidence about how to best support younger people or older people, so people at the extremes of our age range that we included. And finally, we didn't find that many papers really that included people who had comorbid severe mental illnesses or substance misuse difficulties. So overall, I think our conclusions are that the preliminary evidence suggests that people do actually engage and improve with treatments. And this is somewhat contradictory to one of the many issues that come up during our qualitative work, which picks up on a certain degree of therapeutic nihilism in relation to this group, the sort of sense in which people are untreatable. In fact, we found evidence, or we believe that people do really benefit from care, and it is not true that it's particularly difficult to treat or unusually difficult to treat people in this group. But in terms of how we develop good quality, accessible services, much more evidence is needed. So there's, in our view, a much greater need, or a need for for greater emphasis on co-produced research and centering service user and carer priorities, as identified in the work by Una and Kylie, who will come after me. And finally, we know that these conditions, traditionally known as personality disorder, do have this sort of great potential to be treated, but 240 papers in total over 30 years compared to other mental health conditions is really a very, very small literature, and there's a huge amount more work that needs to be done to explore what works best and for whom. Thank you, Sean.
Okay, thank you very much, Luke. And without further ado, I'm going to hand over to Kylie Trevelyan, who will talk about the service user experiences and perspectives of this study.
Thank you, Tina. So my name is Kylie, and I'm also a researcher on the Policy Research Unit. I'm going to talk about a piece of work that we did as part of this research programme, which undertook 2 detailed studies that examined qualitative data. We conducted a qualitative interview study with a group of people, and we also reviewed the international qualitative literature to explore how service users' experiences of using community services for their mental health. Next slide, please. So the first study, the qualitative study, as part of this, we interviewed 30 adults across England who identified as having complex emotional needs that might be related to characteristics that meet the diagnostic criteria for personality disorder, or people who may have been given a diagnosis of personality disorder. We wanted to understand their experiences and views of using a range of community services. We interviewed people who had a range of community service use, so not just within statutory NHS services, but also voluntary sector services and use of specialist community, as they're called, personality disorder services. We looked to sample people to get a range of diversity in views with respect to age, sex, ethnicity, regional spread across England, and, as I mentioned, experience of different service use. Our research team included lived experience researchers, and they led primarily on conducting most of the interviews and on the analysis for this piece of work. Next slide, please. Just to give a description of what we did as part of our review of the international literature, we undertook a systematic review. So we tried to find all of the existing evidence across the world, globally, on service users' experiences of community care. We searched for published papers that had been published since 2003 onwards, and that was partly so we could ensure that the kind of summaries that we were giving from this work is meaningful to how services operate today. We identified a total of 47 papers, 28 of those were from the UK, and these papers reported on the experiences of around 1,500 people. Next slide, please. So I'm just going to highlight here 5 key themes that we picked out and how they're related between both the interview study and the global literature review. So we found many parallels from these 2 pieces of work. The first theme, the need for a long-term perspective. This describes the need for services to take a long-term perspective in supporting people with complex emotional needs. Service users explained that they wanted services to address their ongoing needs by supporting them over a longer period. They wanted services to recognise that their needs may fluctuate, and if only providing support in periods of crisis and not during periods of wellness, then often many of the gains that they might have achieved or their other needs are not adequately supported, and people find themselves needing to come back into services. The data from the meta-synthesis also highlighted that service users wanted services to have realistic views about what constitutes recovery. And what they talked about is recovery should be considered not just in the context of a total absence of needs, but actually an understanding that recovery should be contextualized within an improved ability to manage the needs that people have or the negative impacts that those needs may have presented. Then point 2, the need for holistic and individualized care. This describes, service users described how services often failed to support them in addressing full range of the needs that they had, and focused predominantly just on psychological or pharmacological approaches. But many service users wanted help with not just their presenting mental health needs, but also a range of other needs in their lives, such as housing, benefits, employment, social networks, which for many they felt were equally, if not more important than their mental health needs. They explained that if there was a failure of services to recognise and address these social needs, then it often meant that they were offered forms of support that were either not sufficient or that they couldn't actually engage with because of the demands of their other needs. Linked to this, service users spoke of the need for services to take the time to understand them as an individual. They wanted staff who were actively listening, demonstrating compassion, and through these activities would be able to develop a detailed understanding of the experiences and needs of that individual. And this helps to ensure that they are then supported in the right way. So rather than kind of taking a one-step approach and applying that to everybody, really understanding the individual needs and experiences of each person. Related to this, service users spoke about having an open dialogue, so helping with them so that staff are able to develop support plans that are actually collaborative and reflect the experiences and needs of individuals at that time and take account of how they might change over time. And finally, this theme describes the value of services adopting a trauma-informed approach, and this is something that Luke touched on in his previous presentation. And this, what service users talked about is the value of services acknowledging that many people experience trauma and that the services themselves take steps to ensure that their services are looking to promote people's safety and empowerment and their choice. Next slide, please. The third theme, interpersonal connection and therapeutic relationships. This describes the critical importance of staff developing a positive interpersonal connection or therapeutic relationship with service users. Service users explained that they wanted that positive connections with staff arise when they are warm, validating, respectful, and non-judgmental, when they understand and are responsive to the changing needs of service users. They explained how a positive interpersonal connection can help foster trust over time. And so services talked about the importance of services carefully managing instances where there needs to be staff changes, which would require that service user to then have to develop this rapport and connection with a new member of staff and begin that whole process again. If the services take the time to understand the needs of services, then they also should think about how they're going to support them at periods of time when they may come to discharge from those services, and if they need any other supports ongoing outside of that service. Theme 4, stigma of personality disorder diagnosis. This was a really recurring theme in both of the pieces of work, and it describes the common experiences of stigma that service users have faced across a range of community services. And the stigma resulted in them being treated poorly or even excluded from accessing services. Service users reported some experiences of stigmatizing attitudes among staff with respect to how they might interpret the diagnostic label and perceiving it as meaning that somebody cannot be helped, that they depersonalize that individual, and they may see that individual as a potential troublemaker. And these experiences could be pathologizing and harmful for people. From the qualitative interview study, several service users described how services failed to identify or acknowledge the extent of their mental health need because of their physical and verbal presentations. So they were seen as being, because they were seen as being able to communicate articulately and their needs and their experiences, that may be interpreted by services as them having less needs and being more well than actually was the case. So as a consequence of this, many service users found themselves advocating for themselves in order to get the right level of support from services. And they really actually wanted services to be able to provide that support for them. It demanded a lot of them to do that. Next slide. And the last theme talks about the variations in the accessibility and quality of services that we see across the national picture. So service users described how there were geographical differences in what services were available to support them. So in some locations, there may be a number of services, and in others, there may be few or even none. It also describes some of the challenges that service users experienced in getting access to specialist community personality disorder services. Linked to this, service users spoke about how services can often be disjointed from one another. So they're delivering very discrete pieces of support or interventions within each service, and they're not working collaboratively together to coordinate the needs of service users. This then created challenges in ensuring that service users' needs are met holistically. Service users also spoke of the importance of being able to receive immediate support for their presenting needs, so they received the right care at the time when they needed it. Yet many of them spoke of difficulties in getting the right timely support due to maybe wait lists of services, or for some, the high thresholds of access to some services, which meant that they had rigid inclusion criteria, so only certain people could access those services. And next slide. So this slide is very detailed, and I know that the writing is very small, so I'm not expecting you all to be able to interpret and read and consume all of this. Details about this map and also the context around it will be presented in a paper that we're shortly putting into preprint. But I just wanted to sort of highlight here, this represents a conceptual thematic map that we developed as part of our interview study with service users. And what I wanted to highlight here is that our central theme, interpreting the narratives of service users, was that a good model of care within community services to improve the experiences of service users could be if services adopted a relational practice approach. So it describes how not just the way that individual staff operate, but how the organizational structures of services can work in a way which really looks to build a positive interpersonal connection with each individual that understands and has taken the time to recognize and support them with their needs. And this process will help foster the trust needed to support a fuller disclosure and lead to more suitable treatment and general support options being offered. Thank you.
Thank you, Kylie. And without further ado, I'd like to welcome Una Foy, who is going to talk to us about staff views.
Thanks, Tina, and thanks, Kylie and Luke, for presenting before. A lot of what has come up in the staff side of things is very similar. So you're going to hear a lot of similar concepts and similar ideas, which I think is actually quite endearing to the fact that there's a lot of agreement across different sectors and shows kind of where we could make changes. This is only a whistle-stop tour, so do know that there are other themes and other aspects that I won't be able to touch on today that are really relevant in both the papers. So today, next slide, please. Today I'm going to talk about a systematic review and meta-synthesis that my colleagues presented. And this was the first piece of work in terms of reviewing and synthesizing the literature around the views of staff and their experiences of how to provide best practice for those with complex emotional needs and also personality disorder diagnoses. So this was to look across the community specialist teams as well as the community mental health generic services. And within that review, that was done from 2003, there were only 29 papers that looked at staff views and experiences of working in this field and how to deliver best care, and that comprised of 550 clinicians. And I think that harks back to what Luke said around the previous review, in that there's very little work that's been done in this, and considering kind of how big an issue this is and we need to consider it, it is quite shocking that there's so little evidence out there. And only about half of them were from the UK. The qualitative study was our way of doing some of this work. So we wanted to look at the views of staff across a wide range of professions and perspectives to understand how they consider best practice and what are the facilitators or barriers to that. So we conducted a number of focus groups and one-to-one interviews with 50 staff across England who were working in either specialist services or generic mental health services, and this encompassed NHS and also the third sector. So it wasn't only focused on those working within clinical roles. We had 21 professionals who were working in specialist services and the remaining 29 in generic mental health services. The majority were in the NHS, but we did get a number of people from third sector, and this was across professions. So we had nurses, social workers, occupational therapists, psychologists, peer workers, experts by experience, so a whole wide range. Next slide, please. So the first key finding that was going across both of the studies was the kind of how we define good care and best practice. And really across both of these, the idea of person-centered care was really at the center of this, and the need for an investment in that relational practice that Kylie mentioned, as well as being trauma-informed as the core elements that staff needed to address to be able to provide the best care for service users. And just heading on the trauma-informed aspect, because I see there's a lot of chat around that, it was very much around doing trauma-informed care in the right way rather than it becoming a new buzzword. And I think Angela Sweeney's work really touches on this. This is really important to look at. Very much this work was looking at those more universal staff qualities. So it's very much at that staff level. Apologies if you can hear the background noise. So looking at individuals being empathetic, skilled, authentic, flexible, those kind of core aspects that really sit at the core of all the work and care that is usually done. And actually this is often undervalued and not talked about whenever we're looking at evidence-based care, but really kind of as Luke touched on before, the modality isn't always the most important thing. It's about that relationship that the professional has with the service user, and that's kind of at the core of counselling work and everything that we look at in terms of relational practice. Next slide, please. So in terms of this, looking at what facilitates best practice, there were a number of aspects of this, and I'll not be able to touch on all of them, but I want to draw your attention to the first was flexibility in terms of timelines, accessibility, and those aspects that Kylie has already touched on in regards to the service users value and staff value the ability to be flexible to work to the needs of the service user in times of crisis or when things are in less of a crisis, as Kylie has mentioned. The second is the idea of collaborative care and integrated care, and again that touches on something that Kylie's just mentioned in terms of how disjointed services may be. So there was a need that services needed to work together and work as an integrated care to be able to really keep those service users' needs at the core. And I think one way of this that was discussed a lot by our professionals was the need for co-producing and co-designing services with experts by experience to ensure that the service is designed in ways that it balances the needs between the system, the clinician and the user as well. And the third thing that I would like to draw your attention to is in both of these studies that services needed to provide more training, support and supervision for staff to avoid some of the aspects of burnout, compassion fatigue and challenging the beliefs that may create stigma. So there was a need for that supervision or reflective practice to engage with that person-centered aspect of care that we talked about in the previous theme. Next slide, please. Of course, in the interviews and in the literature, it's always barriers that are talked about the most. And I think that we'll try and touch on some of them here, and really that was at the core the lack of access and availability that service users often met, and that was in regards to issues regarding inclusion and diagnoses, as well as the referral pathways that were often difficult and hard to navigate, and that links back to that kind of siloed working that of disjointed services, that it was difficult for service users to move between generic mental health services and specialist services, and at times of crisis and such, and staff were often feeling this as a significant barrier for them to know how they could best provide care for a service user. As I touched on in the previous slide, issues regarding burnout and fear and concerns around risk were significant barriers that were perceived by professionals in terms of not knowing themselves how to manage some of those without the proper support and supervision, but as well seeing those issues coming within their everyday practice, and particularly within generic mental health services, that often staff could be risk avoidant as they weren't supported, and that often led to feelings of helplessness and hopelessness in terms of how can I help the service user best, and feeling that often they couldn't do anything. And within the synthesis study, these issues were also coming through in terms of how those risk aversions and fear could really impact on providing care. Next slide, please. And of course, we cannot talk about barriers without looking at those systemic challenges. So finally, that is one of the themes that came out and was raised, and was particularly linked to stigma and the idea of labelling and the use of diagnosis that, again, Kylie and Luke have already referred to. And that kind of conceptualization that stigmatizing cultures were being perpetuated because of lack of training, lack of support, and for example, students coming onto, placement in a community setting, and inadvertently those kind of per cultures being role modeled and being picked up and perpetuating without really understanding where they're coming from sometimes. And of course, at the core of many conversations, as always will be in mental health services, is the issue of resources and funding, and the idea that limited resources can limit the staff member in terms of what they can do and how they can engage with that. And that what a theme that came up often was that actually this creates targets rather than individuals staff being able to say, actually it's the service user's need that needs to come first. So that those kind of cultures and aspects can really get into a challenging area. And these elements need to be tackled and using things like co-production, having better leadership, and engaging policy and commissioners to be able to change and integrate and see the buy-in in improving things. And I think kind of these conversations we're having today really start some of those conversations to be able to move things forward and understand how we can actually create a change within some of these areas. I'm going to hand over now to the next section. Thank you so much for listening.
Thank you so much, Una, for that. Last but not least, is Paul McCrone, who's going to talk about the health economic evaluation of this. Over to you, Paul.
Thanks, Tina. And Una finished on her final bullet point was about resources and funding. And you would think we've rehearsed this, wouldn't you? Because we moved seamlessly on to health economics, and no conference would be right without a health economic presentation, would it? But we do have to consider issues of cost and cost effectiveness, because we know that resources are limited. There's a fixed budget, of course, for the NHS and social care system. And even if we had more funds available, it'd still be quite right that we make sure that we use the funds appropriately and make best use of them. So we need to think about how much service models cost, how much different ways of providing care cost, but also it's not just cost, of course. Health economics is all about how we combine cost with outcomes. So what level of outcome, what are people's, is their care improving life for them? So we need to consider outcomes alongside costs. So if we go on to the next slide, please. So there's three components to the health economic part of the project. And it does build upon what Luke, Kylie and Una have been discussing already, and what others have been involved in. So but it's looking at things from a slightly different perspective. So we started with a systematic review of existing evidence. So existing economic evaluations of interventions for people with complex emotional needs. It turned out that when we were looking at the literature, most studies tended to talk in terms of personality disorder and diagnosis of personality disorder. So we were fairly limited in our literature searching. But we wanted to particularly focus upon evaluations where outcomes had been looked at alongside costs. So not just cost studies, we wanted to look at studies that combined both. And we focused on studies that were looking at care that was provided in community settings. So not predominantly hospital-based care, unless there was a community element to that as well. The second part was to look at routine data from secondary mental health services to try and understand what services people were actually using from the specialist care sector, what the cost of care was, and also to then find out, well, why might costs differ between different people using services? So what were the demographic and clinical and other factors that may be linked to costs? So could we explain variations in costs with background variables, background factors? And finally, we want to do some modelling of what the potential cost effectiveness of innovative services might be. So either looking at specific therapies, for example, DBT, and I'll mention that a bit later, or indeed whole models of care, whole service models. And that's something that we're continuing to explore at the moment. So they're the aims and methods. So I'll take each of those in turn fairly briefly. So first of all, the systematic review. We're quite a tight inclusion criteria as part of the systematic review. This is the paper reporting this has been submitted. So we've got comments back, so we're responding to comments, and there is a preprint version of this paper. We identified 18 different studies that met our inclusion criteria, and you can see on the slide there covering a whole range of different ways of providing care, so DBT, so dialectical behavioural therapy, cognitive behavioural therapy, and then various other models. I won't go through them all, and from a number of different countries, UK, elsewhere in Europe, Australia, etc. And yeah, so 3 studies were looking at DBT, and 3 CBT, and 3 step care, and then fewer in all of the other areas. So a relatively limited number of studies included in the review. And what did we find? Well, it was a bit disappointing, really, to be honest. From the review, there was limited robust evidence that suggested that any specific or particular type of therapeutic approach was particularly cost effective. There wasn't really a clear message coming through the review. One of the characteristics of the studies included was that the sample sizes were often very small compared to other studies in other areas. None of the interventions that we looked at appear to be co-produced with service users. So some of the things we've been hearing about earlier, they weren't picked up in the review. And for those who are familiar with how we do economic evaluations, we often use these dreaded measures called QALYs, quality adjusted life years. Some of you may know about those. It's meant to be it's a generic measure of health related quality of life that in theory allows policymakers to make comparisons across totally different health and social care areas. Which in principle sounds good. What in practice, it means that the outcome measure is often somewhat reductionist and quite limited in its scope. And many of the studies used a particular measure called the EQ5D, the Euroqual, which I use in a lot of my work. So I do use it. But in this particular area of complex emotional needs, it's arguably rather too limited. Given all of that, the strongest evidence from the review was for dialectical behavioural therapy. in terms of the relationship between costs and outcomes. It did seem to produce the greatest improvement in health-related quality of life for the cost of that particular therapy. But there was some evidence emerging as well for the cost effectiveness of other interventions and therapies, so schema-focused therapy, joint crisis plans, stepped care, NIDA therapy, psychoeducation with problem solving, and manual assisted cognitive therapy. Sorry, I should have had that on the right there rather than just the acronym. Okay, next slide. So with the systematic review, and as I say, we're responding to comments on that, and it may change slightly. The second part was the analysis of routine data. We identified people using services from the South London and Maudsley Trust, so an area of South East London that isn't particularly representative of other areas in the UK, so we've got to bear that in mind. And we identified people who had received a diagnosis of personality disorder, so again, or met a particular criteria for complex emotional needs using work that had been carried out previously. So it was a trawling through notes using machine learning methods, etc., to identify a sample. And we looked at people before they'd received a diagnosis and then after they'd received a diagnosis. And we compared people who were receiving specialist care with those who were receiving non-specialist care. They were all receiving care from secondary care services, but some were receiving specialist services for complex emotional needs. And you can see here that comparing those two groups after a diagnosis has been made, there's very little difference in the use of inpatient care, community services, forensic services, addiction services, and rehabilitation services. Only about a third we had in contact with inpatient care, and this was over a prolonged period of time, usually over a year, sometimes 2 years, depending on when people had received a diagnosis. Most people were receiving some community services. Of those, about a third were receiving things like DBT, etc. So most weren't receiving services like that. And go on to the next slide, please. And then what explained differences in costs? What were the cost predictors? Well, how long people had during the analysis period, not surprisingly, was positively related to costs. So the longer we measured services for, then the higher the costs, and that's probably obvious, that bit. Previous costs were also predictive of subsequent costs. The number of specialist care contacts were predictive of cost. And then if people were normally resident outside of the area of the South London and Maudsley, then they tended to have higher costs. And comorbidity, so if there were other diagnosed conditions, or then that led to higher costs also. Okay, if we go on to the next slide. So the modelling component, I won't go over this in great detail because I know time is short, but we produced a model and to try and demonstrate how we might assess the cost effectiveness of something like DBT, which this example looks at. And so we tried to map out a care pathway, very limited. So this is looking at therapy rather than a service model. And we focused on healthcare costs within this. So this is really just serving as an example. And if we go on to the next slide, and this shows what's uncertain within a model like this is how many people would be recipients of something like DBT. The data are not very strong on how many people are receiving therapies or services like this. So we looked at, well, what would happen if those who could potentially receive it, what if nobody received it, and then what if 100% of people received it who could be eligible for it? What would be the impact on the costs? And you can see here that we've got the orange bit is the cost of the DBT itself. And there on the left, if nobody gets it, obviously there is no DBT cost. And as more and more people get it, obviously the cost of DBT goes up. And you can see from the grey bar at the top, this is the cost of inpatient care. and that's coming down as more people receive DBT. So overall, the height of the bars is going up. People are having higher costs as more and more people receive DBT, but inpatient costs are coming down. So there is some cost offset effect here. And if overall costs do go up, is that a bad thing? Well, no, not necessarily, because if outcomes are improved, then the higher cost can be entirely justified. This is purely an example of how we can look at the cost effectiveness of different ways of providing care, focusing on DBT. We could apply this to other methods, and we are looking at how we can actually potentially model the whole a whole package of care, not just looking at one particular type of therapy like DBT. So if we go on to the next slide, which I think is my final one, so implications and further work. So the published literature that we reviewed doesn't really provide great evidence about what is cost effective and what isn't, but there seems to be some evidence in favour of DBT. The analysis of the routine data suggests that there's little difference in cost between those in contact with specialist services and those who aren't. And then we're doing this modelling work. So this is quite limited at the moment, and we're in discussions at the moment about how we can enhance the modelling using data from some of the early implementer sites, and that's all to be agreed at the moment, whether we go ahead with that aspect of this work or not. But yes, hopefully it is work in progress. Thank you.